Right, good morning and thanks very much. The topic of my talk, I don't know if I can go back to a slide, is that the optimal treatment for the failing prosthesis is redo surgical AVR. I was assisted by a registrar colleague, Mr. Carlo Olivano, in getting much of the data together. Failing surgical valves might all seem rather like each other. They might have different sizes, but they're not attached to similar patients. And the decision that we have to make ultimately is for the individual patient. Now, there are some cases where undoubtedly redo-SAVR is either preferable or obligatory. And one case, for example, is endocarditis, where there's no alternative choice. There's no TAVI choice. This isn't a great graphic as far as the morphology is concerned, because by implication the patient's already got a valve in place, but there can be anatomical reasons, such as a very hypertrophied septum, for example, that would contraindicate a TAVI valve, perhaps peripheral vascular disease, or when you know there's going to be severe patient prosthesis mismatch, concomitant procedures, and also in the very young patient or relatively young patient. There are also cases where undoubtedly a valve-in-valve TAVI is going to be preferable, very elderly, frail patients, patients where even with mini stenotomy, rehabilitation is going to be an issue. Perhaps the largest group that at our center we would always explore a valve-in-valve TAVI would be for patent lemur. Nevertheless, there's a significant group where none of these factors apply and where you have to make a decision. And the evidence, I believe, firmly at the moment is in favor of valve-in-valve, of redo surgical AVR. Don't do your poll yet. I'm having difficulty loading it anyway. So, as far as the literature at the moment is concerned, I'll summarize the three largest current studies at present. The first, from the Syrio-TAVI group, is meta-analysis of 5 observational studies with 342 patients, about 160 to 170 patients in each group. And ultimately, the procedural survivals are very, very similar, as is the 30-day mortality of about 5%, with no trends whatsoever. Interestingly, and this is the only one of these 3 papers that looks at any sort of ongoing survival analysis at 18 months, it would appear that there is a survival advantage to redo SAVR, which I'll come back to right at the end. With regards to primary echo outcomes, when they looked at all 5 studies, there was no difference in the mean postoperative gradient. But one study involved stentless AVRs as the first procedure. And there, as we all know, the type of TAVI valve that can be inserted is significantly better. If one looks at patients with a mean gradient greater than 20 postoperatively, almost a third of the valve-in-valve groups have a gradient that high, whereas it's only about 5% in the redo-SAVR group. If one removes this study and only looks at the 4 studies where there was a stented valve as the initial procedure, then the mean postoperative gradient is improved by 4, and there is a tenfold, statistically, it's tenfold greater risk of developing a mean gradient of 20. With regards to secondary outcomes, there's also no difference in 30-day myocardial infarction, stroke, and kidney injury. Redo-SAVR, unsurprisingly, is better with regards to vascular complications and also paravalvular leaks. Valve-in-valve bleeding and ITU lengths of stay. In these studies, they found that pacemaker implantation was better in the valve-in-valve group. With regards to the next study, Olaf Vandler and Miriam Slashi, they looked at 2 observational studies with 60 and 70 patients respectively. Again, valve-in-valve was found to be better with regards to ICU length of stay and bleeding. unsurprisingly. They again found an advantage to pacemaker implantation, but had a surprisingly high rate, almost 25% pacemaker rate in their redo SAVR group. It was 10% anywhere in the valve-in-valve group. More importantly, in my opinion, were the gradients. And the gradients for the redo SAVR group fell more, from a mean of 32 to 12, as opposed to 33 to 20, with the expected increases in effective orifice area being greater in the redo SAVR group. The mean gradients, again, in terms of patients with a mean gradient greater than 20, again, significantly bigger numbers in the valve-in-valve group. The final study really is from 6 European centers, but led by McGill in Montreal, looked at the experiences of those centers, and they were able to enroll 200 patients with 126 and then 79 in the valve-in-valve group. Importantly, they then did propensity score matching with 78 in each group. And when they did propensity matching, again, no difference for death, stroke, myocardial infarction, or pacemaker implantation, which was very similar. The advantage they found, again, for total length of stay, favoring the valve-in-valve by 3 days. But importantly, as far as redo SAVR is concerned, lower gradients, 18 versus 4, and again, more patients with mean gradients of greater than 20. I've looked at my own experience in this regard. I must thank Clinton Lloyd for not spoiling the figures too much in the early part of my experience. But I have done between 2000 and 2018, I've done 87 redo SAVR procedures where the primary indication for the surgery was to remove a previous aortic valve implantation. 49 of these cases were non-endocarditis, so while some might have been mechanical valves, theoretically, in terms of outcome, these would be patients who might be candidates for a valve-in-valve TAVI as an alternative. 10 patients died, which is an 11% mortality, but 7 of these were from the 38 patients who had endocarditis. Mortality was 3 amongst the, or 6% amongst the other 50, with expected causes of death. I don't have the data here on I haven't put it on a slide for pacemakers, but there was only 1 pacemaker implantation. So, in summary, then, it's an individual patient-based decision, and every patient differs in terms of the best decision. But for a large group of patients, perhaps all those aged 60 to 80 years, and without any comorbidities, we have to make a decision. And the data would suggest, and my own experience and the experience of our unit in Southampton, is that there is no difference in terms of 30-day mortality. The jury's out as far as pacemakers are concerned. 2 studies find it's better in valve-in-valve. 1 find no difference, the only propensity match study. And our personal experience has been, or my personal experience has been, very low pacemaker rate for redo SAVR. The advantage is length of stay and bleeding. The disadvantage, undoubtedly, when the patient gets home a couple of days later and having had a blood transfusion, is that the patient has less patient-prosthesis mismatch, has better gradients, and the hospital manager is smiling because it's cost a whole lot less. And Torsten touched on this in his talk, but there's an elephant in the room, even though the data already points to the fact that as far as the patient's concerned, it's better, I think, to have the redo SAVR. It's the cases that have been reported of early severe calcification of the valves. Torsten also touched on the valve leaflet thrombosis, which is, for some reason, we're not sure why, 10 times higher in the TAVI valves, being investigated with both the ham And I think HALT studies are investigating why that is an action to take. But this slide, which has not been published, and Torsten showed it, but is very valid, and was showed at EuroPCR, which is the interventional cardiologists' largest European conference, is from Jonathan Webb's group in Vancouver. And Jonathan Webb inserted the second ever TAVI valve. And while these were the original iteration, he's reporting dramatic failures between 6 and 8 years. I believe all the partner 1 patients are now dead, as would be expected. But the explosion of valve implantation in low-risk patients was in 2011 and 2012, and the next 2 years are going to be very interesting. But for the time being, redo-SAVR should be the treatment of choice. Thank you very much.